The use of PARP inhibitors such as Rucaparib always has to be balanced against potential treatment-related adverse events, especially because it's our hope that these patients can continue on treatment for long periods of time. With Rucaparib, the main treatment-related adverse events are fatigue, hematologic toxicity, particularly anemia. When you look at the clinical trials, Ariel 2 Part 1 as well as Ariel 3, one of the more common greater than equal to 3 adverse events was anemia. GI side effects, and what I mean by that is abdominal pain, cramping, or nausea, sometimes constipation or diarrhea. And then lastly, you can see an elevation in the AST and ALT or the creatinine. And what's important is we believe that these elevations of these tests on Rucaparib are not reflective of end organ damage, but rather are reflective of issues with transporters. For example, the MATE transporters and the impact on creatinine. So you want to follow these labs. You may see a rise in the AST and ALT initially, but that should plateau when a patient is on treatment. The creatinine, again, may also rise at initial therapy, but then should plateau. You should not have a patient with a rising bilirubin level. That is not an adverse event. That would concern many of us for disease progression, potentially. And certainly, you can get a 24-hour creatinine clearance if you're worried about the creatinine to assess renal function. Mitigation for these side effects on treatment is really important. And I think of this as a three-pronged approach. One is education, because it's key for patients to be aware of the potential adverse events. 2 is close communication, both with the provider and the staff. And 3 is early mitigation strategies. So for us, the fatigue, for example, patients are going to experience fatigue. You prepare them, you counsel them, and you educate them that that's a possibility. You have them take a nap if they need to. But in parallel, you make sure it's not another issue. They're not hypothyroid, that they're getting physical activity as tolerated during the day, that they're not anemic, because anemia can cause fatigue. With the GI side effects, we make sure that they have antiemetics prescribed for them and available for use, so that if they get significant nausea on treatment, they can use that medication. With respect to the anemia, it's following their blood counts. And ultimately, with the hematologic toxicities, it's dose interruptions and dose reductions as deemed clinically appropriate based on laboratory evaluations. And we shouldn't be reluctant or shy to dose interrupt or dose reduce with Rucaparib as a PARP inhibitor if needed based on hematologic assessments. These drugs do have a rare but potentially life-threatening side effect of MDS and AML. So we don't want to ignore long-standing hematologic toxicity if it doesn't correct with time.